Ladies and gentlemen, thank you for joining the Lake Superior Quinn QIO Addiction Treatment Series webinar. Your host for today, Mark Lausch, will begin.
Thank you, Katina. Good evening. Good afternoon, everyone. My name is Mark Lausch from Lake Superior Quality and Innovation Network, and I'm really pleased today to be with you to introduce you in just a minute to Dr. Corey Waller, who's going to do his first of a three-part series on addiction medicine. Before we get going, I need to read a continuing education disclosure and then do a brief bio of Dr. Waller, and then he will take over. Thank you all for being here for today's Lake Superior Quality and Innovation Network LAN event, our three-part addiction medicine series. Metastar is providing continuing education for this event, so we need to inform you that no commercial support has been received for this learning activity. The speakers and planners have reported no conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation, which will be emailed to you at your registration email address. Social workers who would like CE credits must complete the online evaluation, again, which will be emailed to you a few days after the event today, and a post-test will be included in the evaluation. We encourage everyone to complete the evaluation to provide feedback on the session. So now I'd like to introduce Dr. Corey Waller to you. Dr. Waller is an addiction, pain, and emergency medicine specialist, now a principal consultant at health management, and chair of the Legislative Advocacy Committee for the American Society of Addiction Medicine, or ASAM. In these roles, he is directly responsible for consultation regarding addiction treatment ecosystem development and education, as well as all Washington, D.C. related matters for ASAM. In his immediate past role as Senior Medical Director for the Education and Policy at the National Center for Complex Health and Social Needs, he was responsible for developing and maintaining all training and in-person technical assistance delivered by the National Center. Before joining the National Center, he worked for Spectrum Health System in Grand Rapids, Michigan, which is a fully integrated health system with 12 hospitals and over 1,000 employed physicians. He was the medical director of the Spectrum Health Medical Group Center for Integrative Medicine, the medical staff chief of pain medicine for the Spectrum Health Hospital System, and the president of the Michigan Society of Addiction Medicine, as well as substance use disorder medical director at Lakeshore Regional Partners. So without further ado, we're very happy to have Dr. Waller here to present to us today on addiction medicine. Dr. Waller, take it over.
Thank you, Mark. I appreciate that. And, I think we're going to start a little bit from where I started before addiction became a primary focus of mine, which is really on the subset of the population that meets that 5% of healthcare costs. And that 5% of the population that really chews up 50 to 55% of healthcare costs, depending on how you calculate it, and figure out really what role does addiction play in that. But we're going to have to walk through a few different phases before we get there. And I will say that when I started the clinic, the Center for Integrative Medicine at Spectrum, it was to identify purely those patients who were in the ER 10 or more times per year. And then since then, I've expanded out and been able to see probably 70 different clinics dedicated to many different high-cost populations around the country and about 300 different hospital systems that work on this problem. And I've been able to really narrow it down to a few, root causes for that cost. And I'm going to focus on those for this talk, and then we'll dig into addiction toward the end. But I think it's important to understand that addiction does not occur in a vacuum, and a lot of the stuff that we do in healthcare is not necessarily built to really handle the root cause of that cost and the patient's instability. So we'll start with that and then move forward into the different pathways. And the overarching theme is we should always be treating the cause and not the effect. And keep that in mind as we walk through a lot of these. And as stated earlier, I don't have any disclosures. I don't get any money from pharma, never have, or a device. And then that's made things actually relatively pleasant. I'm not sure if they'd want me to give a talk for them after a lot of the things that I've said. So if we move into what I call kind of the avalanche effect, meaning that if you start at the top and you don't take care to shore up the side of the wall, but things just continue to tumble down. We all really start with this genetic inherited predisposition for who we are, our DNA. And what we've learned is that everything that occurs throughout our lifetime affects the epigenetic changes of that, which means if you are in high-stress situations or you are using drugs on a regular basis or you have significant poverty, early life trauma, all of these things actually change the way that the genetics perform and ultimately are directly responsible for what we found out to be our phenotype, how we turn out and appear to other people. And some recent studies over the last 5 years have identified that not only does it change how we interact with the world and how our DNA interacts with the world around us, but it actually is heritable. And many of these epigenetic changes that happen at the subcellular level change the way that the DNA is turned into protein, and when that happens, it may go down, it definitely 2 generations, and we have some good data to show that it may be as long as 7 generations out before we clear out those epigenetic changes to a given environmental challenge. And that's important to understand because many of the things that affect us, we hope don't affect our offspring, but ultimately in trying to prepare for the world that they're about to walk into, the body does make a lot of changes that in theory enable them to come out more prepared for things like famine and war and risk and or abundance of food, and changes their metabolic approach to what they interact with. So all of these things become really important, especially when we start to look at things like early life trauma. The adverse childhood event studies that have been now going on for a couple of decades really have pointed out, along with all of the neurobiological evaluations that have gone with it, including functional MRI, functional psychological testing and all of this, identifies that early life trauma triggers a cascade of these epigenetic effects. And those epigenetic effects then further change the structure of the brain. And as that structural aspect of the brain changes because of that early life trauma, we found that it ultimately decreases a person's buffer for things around them. And that feeling of decrease in safety, meaning not feeling like you fully belong, being in a heightened sense of alertness, and not being able to feel calm in a basic situation, and be really unable to build what we would call an authentic healing relationship. And these authentic healing relationships are those that are of the nurturing type, the type that creates sustainability and comfort and the ability to lower ultimately things like cortisol and norepinephrine and glutamate release so that we can have a lower stress environment in which we live. And so if we've had this genetic predisposition, and let's say we were born into poverty, we've already had this set up from the epigenetic changes from our parental passage. Now we've had our own early life trauma, and whether that is physical trauma, emotional trauma, sexual trauma, neglect, which is the most powerful form of trauma for making epigenetic changes, we've had this decrease in this buffer, and now all of a sudden it increases our risk for what I call the Sentinel Syndromes, which are really these 4 components of disease that are not just the disease because they always impact things around it, and that would be addiction, mental health conditions, poorly treated chronic pain, and cognitive impairment and cognitive disorders. And that cognitive impairment and disorders really is the subset of patients who live on the autism spectrum, those with traumatic brain injury, those with super low IQ. That subset of the population may start off physically healthy, but because of the different way that they interact with the world around them, standard approaches to medical care tend to make them more expensive because it's not translatable to them because of that cognitive deficit. And poorly treated chronic pain, because that changes sleep patterns, emotional stability patterns, it decreases capacity to have interactions and to work. All of those things start to deteriorate the life around that patient and put them in a high risk of developing other issues down the road. Mental health conditions is pretty self-explanatory, and then addiction itself as one of the most underdiagnosed ailments that we identify in patients, and that 5% that costs 50% of healthcare dollars. If we start, look at this, we also, if you have any one of these, that significantly increases your risk of homelessness and incarceration. So if you take a look at the subset of the population that is homeless, and you do deep dive evaluations of them and identify purposes of being homeless, 90% of those have an untreated or poorly treated mental health disorder or addictive disorder, or a significant cognitive impairment. This old adage that I was taught and actually talked about for a little while as an emergency medicine doc was, well, some people just prefer to live kind of out in the open, and the nature was really a naive statement on my part once I started doing research in this area and digging into the subset of the population. And once you stabilize an addictive disorder or you stabilize a mental health condition, they tend to not want to be homeless anymore. They would like to actually have a roof and a place to go and something of their own. And so focusing just on homelessness without focusing on stabilizing a patient in the syndrome of addiction or mental health condition or this cognitive impairment or even a poorly treated debilitated chronic pain syndrome really by itself doesn't do much except offer a temporary roof that many times is temporary because the disease entity itself will push them toward not being able to be stable in that housing, and thus that would increase their risk of incarceration down the road just by sheer happenstance and being in an interactive capacity with police on a more regular basis. If we start looking at what that leads to, we have is inconsistent transportation that occurs because if you're homeless or incarcerated, it's tough to get a job and have consistent transportation. Then we can have this unpredictable communication from these patients, meaning they're not able to pick up a phone and call us, and we can't call and coordinate with them about what it is that they need to do. And then when we look at this lack of care coordination that happens, it ultimately comes down to a completely discongruent life at that point where they don't have a place that's stable to live. They may be in and out of jail. They definitely don't have, transportation that can get them there exactly at 10:15 for an appointment that they want to follow up with. And the fact that you can't call them and just give them an appointment reminder, or they can't call if they have a question because they don't have access to that, leads to this lack of care coordination. And this overall lack of care coordination really starts to lead down the further path of an increased risk of what we see as the diagnoses, the labels that we give patients that we treat, which is diabetes, COPD, hypertension, CHF, sickle cell, morbid obesity, poorly, the prenatal care required for pregnant populations. And what we do is we tend to focus purely on these as the indicator of how we are going to, approach the subset of the population. And most of our programmatic efforts, as well as the vast majority of money that has trickled down within the mainstream medical capacity, has focused on these disease entities, despite the fact that these are absolutely these are the effect and not the cause. And so what we have to do is continue to move further and further upstream to be able to identify and treat these patients prior to them developing poorly controlled diabetes, end-stage COPD, hypertensive urgency or emergency, and CHF, and get them earlier. And so treating the diseases, or what I call the Sentinel Syndromes, treating those 4 Sentinel Syndromes allows for us to act in a capacity of prevention rather than just reacting to the disease that we see. And I'm going to start with talking about the Sentinel Syndrome of Addiction, because I think that is the one that obviously is the hottest topic right now, and we're trying to figure out what to do. I mean, overdose is the number 1 cause of death in people under 50, and is the number 1 cause of preventable death overall. And that's saying something. I mean, 70,000 people died of opioid overdose in 2017, and they're predicting an even higher number, in 2018. So as we start to develop the approach to this crisis, we need to start thinking about the fact that while opioid and addiction is one piece, but addiction as an overarching theme encompasses a bunch of different behaviors and chemicals, and just focusing on one is not going to build up this system. So in order to understand why we need to build a system of care, or ultimately a line of service around addiction medicine, I want to walk through quickly a little bit of the neuroscience of addiction. And this is the very short version of the lecture I've been giving for a while. And if you think about a patient, they ultimately need three things to survive, right? Food, water, and dopamine. And yes, my scientific colleagues will tell me you need oxygen, and yes, we need skin, but at the same time, we're going to focus on the food, water, and dopamine piece of this. So when we look at this approach to, to humanity in this, we have developed this need to survive, and that survival means I have to eat, and I have to drink to survive, and the coalescence of that motivation to survive comes from internal dopamine in the structures of the brain and the reward system. So it lives in places like the nucleus accumbens and the ventral tegmental area within the brain. And as I talk through the rest of this lecture, I want everybody, when I say dopamine, to think the term motivation, or if I say the word motivation, I really mean dopamine, because they are interchangeable with one another in how we should be perceiving it. And we've done a lot of research in this area to understand the amount of dopamine that needs to be produced in the central part of the brain to create regular daily motivation. So to get up in the morning and get out of your door, you need about 50 nanograms per deciliter of dopamine. And this has been through micropipetting studies, followed by functional MRI studies and all of this. And so this 50 nanograms per deciliter is what gets you out the door in the morning. It probably took a little more dopamine to get on the phone to listen to a webinar in the middle of the day, but that's the basic. And we know, like, our bad days, the day that you pick up the phone and you fake vomit on the phone and you call in sick and you do whatever you can to get out of work that day because you just need that mental health day, that's 40 nanograms per deciliter. I mean, that's so about 10 nanograms less. And like the best day ever, the day you win the lottery and the day that you have immediately 2% body fat, all of those things happen at one time. And, that's the day that you reach that maximum of about 100 nanograms per deciliter. And then we look at some of the other things, like favorite food ever, and that's about 94 nanograms per deciliter. Sex is 92 nanograms per deciliter. So bummer, but maybe that research needs to be redone, but that's where it sits. So we know, however, where we need to be in order to feel like a normal human that has bad days, has happy days, has elation, and those are the natural stimuli that release that dopamine. And as we see that, that means that when I see my kid play soccer, I get a dopamine bump from that. And if it's a birthday or, it's just I've been on a trip and I come home, those are things that naturally raise dopamine above that standard basic level. Well, when we use a substance, especially for those patients who have had early life trauma and epigenetic change due to stress in the previous generations, and our brain hits one of these drugs, whether it be nicotine or alcohol or marijuana or methamphetamine, then we get a massive increase in the release of dopamine far above 100. So I talk about 100 as being, about the maximum that we should have on a natural basis. The other piece is that if you use methamphetamine, then it goes up to about 1,100 nanograms per deciliter, so far beyond what it should be. And then, heroin is in the 900s, and marijuana is in the 500s and 600s. And so when we look at the best day ever and then compare these other drugs and what they do to the brain, what we identify is that the brain is now being stressed way beyond what it needs for normal motivation and normal dopamine release. And it does not like that. And it fights back vigorously, and it fights back by lowering the amount of dopamine that we have and lowering it even more over time. And the longer you use, or the higher the dose of drugs that you use, the more the body will first decrease the amount of dopamine released, followed by the amount of dopamine produced, the size of the neurons that produce dopamine, and then finally we have, unfortunately, data that shows that there's apoptosis that occurs where you actually get programmed cell death in the central, part of the brain responsible for reward. And so when this happens, it's the equivalent of having a stroke in the happy part of the brain. And when we have that, there's not really any coming back from that. And so there's a subset of the population within the population in recovery or active addiction that if they don't use a substance, their dopamine level isn't 40, it's 10. It's 15 nanograms per deciliter, and if 40 is the day that we call in sick, imagine being a quarter of that amount, and then trying to get up and do anything for any part of life, especially getting up and going to a doctor's appointment, or getting up and going to to stand in line at the DMV to get a driver's license. I mean, all of these things become Herculean efforts without the appropriate amount of dopamine. And, we know the areas of the brain responsible for all of these issues, and I bring it up not because I expect everybody to be a neuroscientist, but if you break your humerus, we know what that is, and we show the patient, and we teach them about where that bone is and what we're going to do. Well, we should be teaching each other and patients that if you have a relapse, that cue-associated relapse occurs from the anterior cingulate gyrus, that the reward system lives in the nucleus accumbens, and motivation lives in the ventral tegmental area and the nucleus accumbens. That the amygdala is responsible for fear, but also the place we store our emotional memories. And that the periaqueductal gray is the part of the brain that modulates most of the pain, and especially our perceptions of pain when it comes up through the spinal cord. So the vocabulary that we give our patients and use when we talk to our patients becomes really, really important in this. And all of my patients, when I would see them and they would be released, they really did understand this terminology. We would have the conversation about their nucleus accumbens. How's your dopamine doing? How's the nucleus accumbens doing today? And while that seems silly, it actually empowers them to understand that this is a structure. It's a real thing, that it's not a figment of their imagination. And as we, start to look at the behaviors of patients that, for me, when I started in emergency medicine, were terribly frustrating, I find that it's really easy to begin to explain those behaviors when I understand the realities of addiction. And when you understand the realities of what's happening in the neurobiological aspects of addiction, then you can start to understand, when you see a behavior, that behavior really is a symptom of a disease and shouldn't be seen as a frustration. And, we don't see hallucinations as a frustration in the schizophrenic. We just know that that's a type of their disease process. And the worse those are, the worse that the patient's disease is, and the more rapid we need to approach them and treat them. Well, in addiction, behavior is, how we define this disease. And when you have this lack of dopamine, you get craving. And craving, just to give a very quick piece, is there's been research done on functional MRI studies for people who had not had any water for 3 days, and then they functionally MRI'd their brain. When they're in the MRI, they're talking about water, they're like splashing water on their feet, they're playing water sounds, and they functionally MRI their brain, and they find that this a relative size of a baseball of craving in that anterior cingulate gyrus and anterior lateral dorsal funiculus, and those areas, really have this significant amount of craving for that. But then they also did it with lack of food for 5 days. And then they put people in a functional MRI, and they brought in their favorite food. They kind of wafted it into the MRI tube and had them talk about it and think about it. And that was about the relative size of a baseball. But when they functionally MRI'd people who had been off of their drug of choice for 30 days, 60 days, 90 days, and then even further out, a year, year and a half, and 2 years, what they found was that the craving signal in the brain of a person who has not been on their drug of choice for that period of time was about the size of a baseball field. I mean, so it's a logarithmic change in the amount of chemical craving that's going on in the brain. And so that drive from that craving leads to survival mode. And that survival mode, leads to these primal actions that we see. And some of the smaller ones are, you steal money out of, your parents', purse. You steal a credit card. You take some clothes off of a rack and try to steal those things. But in my time, in my patient population, I've seen people sell themselves so that they can get drugs. I've seen them, do hugely felonious actions in order just to obtain those drugs. And what they get from that drug after a period of time is not being high. It's just feeling normal because their dopamine is so low at this point that when they use the drug, it just keeps them from going into withdrawal, and it stabilizes them to feel kind of, quote, normal. And this is how, we have the data to back this up, but also just seeing hundreds of patients over time, I hear the same story over and over and over again, which is why that leads us to a lot of the pathways that we use for treatment. And if we look at the diagnosis matrix of how we diagnose addiction, it's all behavior. There are only two physiologic phenomena, tolerance and withdrawal. But if we're prescribing a pain medication for a patient, they're going to have tolerance and withdrawal, so those are just basically eliminated. And everything else is the behavior associated with not being able to control the use of the drug, or the impairment that it creates in our social setting, or us doing risky things in order to obtain or use the drug. So those are all behaviors. So this really does need to lead us to understand that the neurobiological concept of addiction is one that ultimately changes the brain to be in survival mode all the time. And if you're dying of starvation or dehydration, we know that people will do amazing, kind of sometimes crazy things. They will, take food from a store after a big storm. They will steal from other starving people to save their own life and their family's life. And we can justify that. But when we're talking about someone who has structural changes in their brain secondary to using drugs for an extended period of time, and they have 10 times the amount of craving, that helped me as an ER physician to really begin to understand why my patients would act in the way that they do. And then when I went and got trained in addiction medicine and pain medicine, it helped me to know that this was definitely not something I should be frustrated with, but flipping that frame to recognizing that those behaviors, which many times can be disruptive and feel very personal, ultimately are just a symptom of the disease. And it's a symptom of the disease that we actually have good data to treat. And so as we go through these things, I want you to think, as we start to talk about the system of treatment of addiction, that we are thinking about treating a chronic neurobiological disorder that has predictable behaviors and evidence-based treatments. Not unlike any of the other chronic diseases that we treat, it's just that we, as physicians or PAs or nurse practitioners, we're just not well prepared for this. I mean, I trained at a really good institution in Philadelphia, Thomas Jefferson, and felt very prepared if you got shot in the chest or stabbed in the belly. But when I started seeing patients with kind of just life suffering in the emergency department, I wasn't equipped for that, and it was frustrating. But after, being trained in addiction and pain and going back, and now I actively work in the emergency department again clinically, that's my main clinical work, it makes it pretty easy. It's a whole lot easier than it ever was because I see it just as a symptom, no different than chest pain, no different than hyperglycemia. And because of that, I don't take it personally, and it allows me to work through a shift pretty easily and deal with really complex patients with complex behavioral outputs that I wasn't able to before. But this behavior and this dopamine pathway also leads to why we have the treatments that we have. So if lack of dopamine is really the basis for this behavior, then it does make sense for us to augment dopamine. And we do this for serotonin in a low serotonin state, like major depressive disorder. And when we do that, it raises serotonin, and over a period of time, the brain starts to restabilize all of the surrounding mechanisms of serotonin and moves forward in stabilizing that depression in a large portion of patients. Well, it's no different if you have someone with low dopamine production that we want to boost it. Now, we don't want to boost it past feeling normal or a little motivated. We don't want to make it that 300, 500, or 1,000. And in many places, you couldn't even squeeze that out of most of these patients. But that's where things like buprenorphine and methadone come in. Because buprenorphine, being a partial agonist, definitely can raise that dopamine and act as an indirect augmenter of dopamine so that the patient feels normal and motivated, which makes them want to actually show up to an office visit, try to figure out how to handle transportation, to figure out how to handle telecommunication, and go wait in line to get an ID. All of these things that may feel mundane, but they had previously lacked the dopaminergic capacity to motivate to do those things. So when we look at the patient on methadone, it's no different. It stabilizes that dopamine axis. And in stabilizing the dopamine axis, we gain a patient that has those cravings abate, which then takes a lot of those behaviors away so that they're not stealing or selling themselves to get their drug of choice, so that they're having a conversation about improving their health care. Those are the things that we want to be focusing on. And so if we start to look at the treatments of this, there's a lot of this that has to be chatted about, and we're going to do a broad overview, and we'll dig in on each webinar after this a little more. But with treatments, the location of treatment is important because it can be in a hospital, in an emergency department, in a primary care office, in an FQHC, in a methadone clinic, in a residential setting. All of these different places have their place. And then alongside that is, what is the intensity of treatment being delivered within that location? Because in my clinic, we had a fully integrated clinic that had behavioral health, we had RN case manager, we were connected with peers, so we had a very intense treatment portfolio, even though it was outpatient. And then the behavioral health interventions have to be, built to fidelity. And we all know that once the door closes behind somebody giving therapy, we don't necessarily know exactly what it is that is being said. Not unlike, if we look in the EMR, we can all see if we wrote a beta blocker for a patient with hypertension or an ACE inhibitor with somebody with diabetes and hypertension. That we've done these things, these markers of mortality decrease, but it's a little harder on this, so it becomes really important for us to keep tabs on that. And then medication-assisted treatment. I can't talk about this enough for opioid use disorder. It is the most important piece in opioid use disorder for survivability. And the data is pretty clear that starting medication-assisted treatment, specifically with buprenorphine and methadone, and then for a subpopulation, naltrexone, that early stabilization decreases their mortality rate by 50% year on year. That's a huge mortality decrease. If I cardiovert someone, that's only a 30% chance of decrease in mortality. And we put those things on the wall in a Burger King bathroom. So having the access to medications to stabilize the dopamine axis to allow for a patient to jump in is really, really important. So I want to switch gears a little bit and talk about the system of treatment that's required to deliver things like medication-assisted treatment and residential treatment and intensive outpatient. But if we look at this picture, imagine this as the specialty of cardiology, right? So this is, cardiology. You walk out of any of these doors, you look to your right, you got a heart failure specialist, you look to your left, you got a hypertensive specialist, you got an electrophysiologist, you got somebody who's going to do stents, you got a transplant surgeon, you got all of these different modalities. You can get an LVAD placed and, everything. And there's, no matter where you are in the country, you're generally going to have access to cardiological input. If you're having a heart attack in a remote or rural area, we will fly you to another hospital so that you can get appropriate care in that setting. So if this is cardiology, then this is addiction. The addiction treatment ecosystem is bare. It does not have the capacity that it needs. It does not have the capability that it needs. And it quite honestly looks very much like this. It looks like a lot of people shoved into a small space like a residential treatment facility. And then after that, because of lack of care coordination and a lack of a lot of the follow-up care and other levels of care, they just get sent out. And then those, that will cuddle together in safety for self-help capacity, and then others will wander off. And those that wander off are basically eaten by the wolf. And that's just why we're seeing this huge overdose risk in these patients. After an inpatient stay, as we get them there, they feel comfortable, they feel empowered, but then they leave, and we have no transition of care when they leave, and then they're wandering around in the wilderness with no standard capability for treatment, despite the fact that a lot of these patients will just need a low dose of an extremely safe medication in a primary care setting. So if we look at what is needed to treat and interact with the syndrome of addiction, then what we find is that these are the components that are needed in this ecosystem. And if we're dealing with the Sentinel Syndrome of Addiction, this ecosystem has to be built in order for us to really feel that we can really stabilize and continue to treat a patient appropriately as we go. And so one of those would be, obviously, treatment and education. So treatment education, knowing what to do and how to do it is number one. Things like webinars are great, but quite honestly, these can be confusing problems and feel very complex early. done a lot of telephonic technical assistance for people, and it basically takes about 18 months of some backup and somebody to talk to before everybody feels really comfortable using medications like buprenorphine or treating a patient with who's being seen at a methadone clinic or using naltrexone. And so being able to onboard that over time becomes important, and identifying your local knowledge-capable talent and connecting with them on a regular basis is important. We have to have outpatient treatment. Now, outpatient treatment in addiction is what we call level 1. So instead of labeling things primary care, inpatient med-surg, step-down unit and ICU, then what we have is outpatient treatment or level 1, intensive outpatient treatment or level 2, residential/mild detox, which is level 3, and then medically managed treatment and detox, which is level 4. They're no different. We just gave them different names, but these are the levels of treatment that are available throughout all of healthcare for other diseases. If you have DKA, you go to the ICU, you don't go to primary care. But if you have standard, diabetes that can be monitored and treated in the outpatient setting, then you go there. And sometimes you got to bump up to the endocrinologist and get a diabetic education specialist and that. So these exist in every other piece of healthcare. And we know what to build, but they just don't physically exist in most of the communities around the country. Then we have to have screening and referral. I mean, less than 10% of primary care uses a standardized addiction screening tool in order to identify patients with the disease of addiction and set them up for screening, brief intervention, and referral to treatment. And we're going to talk a lot more about screening in the next webinar about how to actually pragmatically set this up and get paid for it. But if we don't screen, then you're not going to find it. You have to look for it to find it. That's huge. And then in every other thing, we do good data collection and evaluation. But because we don't screen, you can't use large data sets, like in a payer, to identify the density of disease in any given population. In fact, data from a payer source at this point is pretty useless for addiction, because we know that up to 12% of the population has a substance use disorder. Yet, if you look at the data from a large payer, you're only finding the diagnosis in 1 to 2% of the total population. So we know it's being, drastically under-identified in people. And what we call it is poorly controlled diabetes, non-compliant patient, a patient with, severe hypertension or, non-compliant COPD. But really, it's addiction, and if we had identified it and treated the Sentinel Syndrome of addiction, then we would be much more successful at coordinating that care and then effectively and consistently treating the diabetes. But if you're trying to take someone who has an active addiction and trying to explain to them how to, carb count so that they can do their ultra-fast-acting insulin, I mean, I'm not sure if we can do a really good carb count after a 12-pack of beer or after, a gram of heroin. I mean, these are things that we need to just be pragmatic and understand. And when a patient is ready to get that information, they will take it, but until we stabilize their disease, they just won't. And social determinants and prevention, I mean, these are obviously huge, but we don't have to fix homelessness. We don't have to fix, all of these, other issues of social determinants. We have to, however, realize that in order to stabilize the patient with an unstable disease, we may have to temporarily house them. We do this for other diseases. We just don't call it housing. We call it, skilled nursing, or we call it long-term care. And so when we put a patient into those, all that is housing. So we don't even need that sophisticated of a level of housing for a lot of these patients, but they may need to be there while we're stabilizing their disease. The clinical structure, I mean, how do you build this? What does a true integrated clinic look like? Is it intensive outpatient treatment where you're seeing patients 9 to 17 hours a week? Or is it partial hospitalization where you're actually seeing them, up to 24 hours a week? These are things that we can add on to FQHCs that operate throughout the whole day without having to add a whole lot of staff. It's just a rotation of what they do. And in a basic primary care setting, you can really build systems of care into primary care that allow for you to be able to bill at a much higher rate and actually make this not only something that feels good to treat because your patients are more stable, but creates a positive margin rather than a lot of frustration. And these are the components that are really required to do a good job. If we look at, the integrated care piece, when we talk about that, it incorporates some version of all of this. So you need a prescriber. It doesn't necessarily have to be an MD or DO. It can be a PA. It can be an advanced practice nurse. We recently, with the new law, HR 6 that just passed, we were able to expand access for getting a buprenorphine waiver, not only to nurse practitioners, but to nurse anesthetists and midwives and another subset of advanced practice nurses. And so as we look at the ability for our PAs and nurse practitioners and midwives to be able to help us with this, the capacity is definitely growing in that. And then support. That could be an RN, it could be an LPN or an MA. You just need people to work at the highest level, of their license. I wouldn't have a nurse doing callbacks for patients unless there's education involved. You can hand that off to a medical assistant. You can have an LPN doing, high-level education for patients if they're trained well enough. So making sure that everybody works at that highest level of their license. Behavioral health, some version of this, and whether it's a bachelor's of social work doing groups, a master's level social worker or master's psychologist doing individual therapy, or a doctor, a PsyD actually doing psychiatric analysis and treatment, some version of that needs to be incorporated into this. And then obviously care coordination. And that RN care coordination should really only be necessary for the sickest subset. And using peer support or community health workers, you can get a lot of this work done. And then obviously, as we talked about, at least having a place to coordinate with surrounding housing and food and safety and education. Some component of each of these, in order to call yourself truly an integrated clinic, one, you can't just co-locate these. You need to actually interact with the people who deliver these. And that's integrated as compared to co-located. So you have each of these things that interact at some level with each other, whether it's a daily huddle, a weekly meeting, but you're really talking about patient-level data and how you're working through the problems that patient needs help with. As we look at this, we talk about addiction as a major driver of complexity. And we talk about lacking even the most basic of infrastructure. But I want to stop on addiction as a major driver of complexity for a minute, because when we start to talk about what even some of these drugs do, and if we walk through each one of the major drugs quickly, if we look at opioids, obviously being on chronic opioids, whether it's for pain or not, you have an increased risk of hyperalgesia, so the response to pain is going to be different. It changes the epigenetics of the brain to the point where they are more likely to have pain from a non-painful stimuli. And then if we get them off of those opioids, we still have to deal with that pain conundrum with these patients and really start to push an entirely different pathway for treatment that's generally non-pharmacologic. What that requires is people inside of the clinic, and not just the prescribing provider, but the people at the front desk, the people taking information, to be trained in basic and sometimes advanced motivational interviewing. I used to think that motivational interviewing was just being nice until I went and actually got trained in it. And what I found is that motivational interviewing is really math. It's a science that of approaching a patient who's not quite ready to do the things that we would hope they would want to do. And in order to apply it, there are techniques that you can use in real time that specifically increase the chances of getting someone to move in a positive direction. Now, interestingly, I have found that motivational interviewing doesn't only work with my patients, it works with CFOs. It works with my children. So it has layers of positive help that it can onboard. But it becomes really, really important for us to start thinking about how do we get someone who has a disease that generally feels recalcitrant and frustrating to want to do more, to want to do better, to be what we would be able to label as compliant. And I have to say, it starts with us, because if we're condescending or mean or frustrated, they sense that and they know that. And that group of patients feels more guilty about having addiction than we could ever make them have. But we just add to it over and over again with frustration and condescension. And we don't even mean it most of the time. And when I've talked with colleagues who've had difficulty with these patients, the vast majority of the time I've identified colleagues who've had family members or close friends who've had addiction and they've been hurt or pushed by them at a point where they have this counter-transference of all of that anger and frustration, and they push that onto their patients with addiction. And in doing so, we dramatically put our patients at risk for not wanting to come and get care and not wanting to return. So it's really important to understand that if addiction is a major driver of complexity, and if you have patients who are, quote, non-compliant, you should really start doing a deep dive evaluation of whether or not they have untreated and unidentified addiction or mental health disorder. Those are things that if you identify them, we have good evidence-based treatments to focus on them. If we have a patient that you've identified that's sicker for you, we know that we are lacking the most basic of infrastructures in addiction treatment. But generally speaking, and this is not in every county, I've identified that for sure, but in most counties and in most health systems, there is someone that you can refer to a higher level of care. And so I would put your office manager, your MA, somebody on identifying where you can refer patients with addiction so that they can get good collaborative care. And collaborative care is very much having a conversation with the person running that institution to identify what it is that they treat, who they treat, when they treat them. And if they do that, then you're going to have a better idea that if you refer your patient, it's not just out to the abyss. And there's going to be some new accountability because they're going to be having a conversation with you and walking through a lot of these pathways. The we know what to do piece is what's most frustrating for me, especially if I have a patient with the most simple of addictions. And I'll say that opioid use disorder is the easiest addiction to treat by far. I mean, without the easiest by far. And we're failing miserably at it because we have a frustration, we put up some fences, we don't want to have to do it. We know that these patients exist within our practices. We know that we may have to start getting, quote, those patients in our office. But these patients are there. And they want help. They may be quiet about it. But the ones that are quiet about it have the mildest form of the disease, which has the highest potential for appropriate long-term treatment. And so getting an X license and writing for buprenorphine or learning how to utilize naltrexone or knowing where your methadone clinic is to refer a patient if they need help, those are all so important. And eventually writing buprenorphine for opioid use disorder or naltrexone for opioid use disorder is just going to be a standard part of practice. As frustrating as it sounds, and nobody wants to go get 8 hours of extra training, but because we never got trained in this, quite honestly, 8 hours maybe doesn't feel like enough. And I would recommend that if you're honestly thinking about taking this on, I would go through the same pathway that the PAs, nurse practitioners, and other APNs have, which is a 24-hour training course to go through. And they're available for free. They will give you a mentor. They will give you someone that you can talk to when you have questions. And they have all of the value stream maps of how a patient should move through your practice. This stuff does exist, and we can do it. So, I would implore anyone on this call that doesn't already do this to just do the training. You can do it mostly online. You can do it all online now. There's an all-online version. Get an X license. But even if you don't write a prescription, at least understand it. But I would say once you treat 1 or 2 patients, you will find that it is one of the most positive interactions that you're going to have because you take someone who has a huge mortality risk of overdose, someone who's devastating their life both at the familial level, the professional level, and just at the basic society level, and you immediately decrease their risk of things like death, HIV, hepatitis C, going to jail, losing their house, losing their job, losing their wife, losing their husband, losing all of these things that we hold dear. A single medication with a caring interaction significantly decreases the chance of that. And when I say significant, I mean p-value of 0.001 significant. In all studies that have been done, those indicators have all improved, which is the basic aspect of adding some medication-assisted treatment. And by doing that, you're not only helping out your patient population, but the community in which you live and work. And that becomes really important within that community that needs to have a healthy access. And for those of you who have children, I mean, mine are 6 or 8, and so I feel really focused on getting to that point as quickly as I can to stabilize the community in which I live. And so now we just need to start doing it. And that's why this collaborative with, NPRO and a number of the other pathways that are happening as the federal government drops billions of dollars at the state level to really start implementing the structures that can be delivered for the treatment of addiction, not only within primary care, but also in the setting of expansion of opioid treatment programs, expansion of intensive outpatient programs, putting in ubiquitous screening. Everybody should be screened for this now. We should have 100% of people screened for addiction medicine. I mean, if we find that they have addiction, whether it be tobacco or alcohol or opioids or benzodiazepines or marijuana, methamphetamine, whatever it is, we have treatments for those. Some are medication, some are behavioral, some are a combination. But not identifying a high mortality disease, especially one of those that would be one of the Sentinel Syndromes and one of the bigger drivers of cost in the U.S., I really think that we're starting to push on shirking our ethical duty as practitioners in this space. And we really should be moving past kind of this historical frustration with it and just move into the next phase, which is treating it on a regular basis. So with that, I wanted to leave a little bit of time for us to have some questions. That leaves us with 9 minutes. So I'm happy at this point to start taking questions either through the chat function, but I'll let Mark help us manage that piece now. So thank you.
Thanks, Dr. Wall. I really appreciate it. Katina, would you let the attendees know how they can ask a question to Dr. Waller?
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. Okay, Mark, our first question is going to come from Gabby. Please go ahead.
I have to get my mute off. Hey, Dr. Waller, it's Abby. I used to work with you at Spectrum.
How are you?
I'm good. How are you?
Great.
Question. So when we have these folks, I have Priority Health Medicare folks on the phone that have been on opioids for decades. And now, their providers are telling them, I'm sorry, we have to cut you off. You have to go to a pain clinic. What's your little ninja thing to those people that absolutely don't want to entertain getting off of opiates? They only want us to find them a provider that will hand them the script.
Yeah, so this is a difficult group, and I kind of break the two opioid groups into really generations. So there's the generation that got on opioids prior to the CDC guidelines, and then there's the generation that is post-CDC guidelines. And the ones who've had surgery since the CDC guidelines are easy because we can set great expectations. But the group that you're talking about is pretty difficult. And so the way that I've approached it with that subset is I let them know that this medication, without question, is doing them harm, for the most of them. Now, some of these patients, I've had patients with non-cancer pain that have debilitated rheumatoid arthritis. They've already gone through all of the pathways of treatment. There are a subset that will need to stay on opioids. It's just probably 5% of the total that we used to write them for. And talking to them about that it's making it worse. And if you can show me any information that opioids are helpful for you, I'm happy to look at it, but everything I find shows that it's basically malpractice for me to continue to write these for you. And why won't you try? Well, I tried physical therapy. Well, let's talk about that. And what was that physical therapy? And if they went twice and never went back, that's not a failure of the therapy. That's a failure of the attempt at therapy. But remember, a lot of these behaviors are going to still come from that lower dopamine state. And if we don't wean them properly, they are going to feel horrible.
Yeah.
And so I would just definitely first say, if you're not going to write opioids, don't fire a patient. Slowly wean them. If they've been on them and you don't think they're diverting them and you don't think that they're injecting them, then, take your time. Decrease it 10% per month. See if you can identify a pain doc. And maybe they won't actually write for the opioids, but at least they can get a specialty evaluation. And with that, try to work hand in hand with the patient to move it down. And I always tell them, I go, look, I don't have a choice but to decrease this. It's just not safe. We just can't. And now, luckily, you have all of this, national data to back it up. Whereas before, like back when I started doing it, I wasn't exactly the most popular guy in the hospital because I was one of maybe 2 docs doing this. and I got literal death threats for the years that I was doing this. But nowadays, everybody kind of knows that this is the case. And I will remind all the primary care doctors on the phone, these are controlled substances. They are controlled specifically by our pen or our electronic health record pushing prescribe. So whether they want to or not, if it's causing harm, it is incumbent upon us to decrease the use of it, and in some cases, in many cases, stop it. But do it in an appropriate, empathetic way, realizing that this is scary for them, that they feel very connected to these drugs, and most of them are very connected to what they felt in pain relief for the first couple of months that they were on them. But that's all gone. And it's going to take a lot of that motivational interviewing to move through and sitting with them, taking pauses in the weaning, listening to them, and handling that, and calling them and having nurses and community health workers or anybody in your office just giving them a call during this wean to talk to them. They just need to feel like somebody's got their back. And it does work for most, and there's still some that are going to be frustrated and they may fire you. But I would still continue to see them and just help work through those problems.
Thank you.
Mm-hmm.
Dr. Waller, we do have a question from the chat. Beth Alvarez asked, do you have an opinion on the preferred clinical environment to host or provider to serve on the integrated team? Primary care, behavioral health, specialty clinics, internists, psychiatrists. So do you have an opinion on the preferred clinical environment to host or what type of provider to serve on the integrated team?
Yeah, no, that's a great question, and it's one that I've struggled with for the last few years in figuring out how do you build these teams, where do you start them, who do you add where. And so it is much easier to add primary care to a specialty addiction treatment service than it is to add behavioral, like meaningful addiction behavioral health treatment to a primary care service. And so if you're a primary care office and you want to onboard this, then the people that you should have as your basics is somebody who can actually do therapy. And this may be not on site, but referred, and you talk with them and you have your one or two people that you send them to and you interact with them, but definitely someone who can do the therapeutic input with this person. And not just chit-chat, I mean real cognitive behavioral therapy or manual-driven dialectical behavioral therapy. And definitely someone who can help to coordinate care with these other specialists and work, not just to make appointments, because quite honestly, having an RN case manager make appointments is really way below their pay grade in a sense. There's a lot more that they could be doing for setting up stuff in their homes and doing that. So just making sure that at the basics you have a provider who talks to a behavioral health individual. And if that's in a primary care setting, then what I always talk about is if you have enough of these patients, sequester a half day or a whole day dedicated to them so that you can change your appointment matrix on your EHR so that your appointments look different on that day as compared to the other ones, so that you don't try to push them through the same number of like 20 level 3s, or 40 level 3s in a day, that you're actually seeing them in the time that you have. But it doesn't really matter if it's a family practice doc, if it's an internist or a psychiatrist. They really just have to want to be comfortable treating addiction, because it requires a mental capacity and a large bucket of empathy to start the week with. And if you have that and all of your people are okay with treating this disease, and it's going to work well, and you can work with just about any team, but you have to have the capacity to either refer or do behavioral therapy, and the capacity to write a prescription for buprenorphine and the medications for alcohol use disorder that we have, to wean benzodiazepines off. Those are the capacities that we're looking for. And that's a great start. And, there is a perfect world, and that perfect world would be to have an RN case manager, a peer, a behavioral therapist, and a prescriber all working together in kind of a team. And you can do that. It's all billable. I mean, you can bill for team-based care, care coordination, and each of these people have billable duties that they can do. So there is a monetary play to be made on this to actually create a solid ROI, but it requires some good lean processing when you start it.
Tina, we have enough time for maybe one brief question, so if there's somebody that's waiting to ask Dr. Waller a question, we can go ahead with that.
And we don't have anyone in queue, but if you have a question, please press the number 1 key. We do have one from John Glover. Please go ahead.
Dr. Waller, I really appreciate your presentation. I wish I had 15, 20 minutes to talk to you further. Really great. I did want to ask you about your comment on the increase in pain sensitivity that occurs, and I was wondering if you found that that also occurs emotionally in terms of emotional sensitivity to, say, the stigma of having an addiction. Do you have any comments on that?
Yeah, it's a great question. And so if you look at emotional lability in a patient who's on a controlled substance, just think about all of the parodies that we see about when somebody gets a little bit inebriated and they're like, I love you, man, and they're like having this emotional meltdown. That's basically what happens if you're on benzodiazepines, too high of a dose, or you're on opioids, is you take away some of the emotional fortitude that you have. And so you're going to see people who get more emotional, both in the sad, more in the angry, more in the insistent, because they're not going to have, we've taken away some of that capacity to buffer those emotions. And then if you look at, on the addiction side, the hallmark of addiction is emotional lability. And a lot of that lability goes to fighting off that craving, because there are only so many times in a day you can fight that craving. And there's good research on that, and I hope to talk about that in one of the future webinars. But yes, emotional lability is a hallmark. So when those patients who show up and are having meltdowns in your office or on the phone with one of your nurses or MAs, these are people who a deep dive evaluation for screening and treatment for addiction would be really important, because it is a hallmark of it. It's almost pathognomonic in a subset of the population.
Thank you.
Yep, you bet.
Okay, thank you, everyone. We're out of time at this point, but please join Dr. Waller and the Lake Superior Quality Innovation Network on November 20th and November 27th for parts 2 and 3 of this fascinating series on addiction medicine. Dr. Waller, I want to thank you for your time and your wonderful presentation. We loved it here, and I'm sure all the participants, all the attendees felt the same way. For those of you still on the line, you will get an email within about 5 days, 5 to 7 days, with a link for the evaluation, and by doing the evaluation, you can download your certificate for your one continuing education credit. There will be one CE for each of the 3 addiction medicine webinar series presentations. So just wait for the email. You will get it from Metastar, our CE provider, and it's real simple. Just do the evaluation, and it'll let you print out your certificate. For social workers, there'll be a brief 10-question post-test that you'll have to answer, but that's pretty easy breezy too. So shouldn't be a problem. So please, again, thank you very much for attending, and thank you, Dr. Waller, and we will see you on the 20th.
Great. Thanks so much. Have a great day.
I would like to say thank you, ladies and gentlemen, for joining. You now disconnect and have a great day.